I would like to talk to you today about the nature of pain. What, in fact, is pain, particularly chronic pain? Without an understanding of chronic pain, it's going to be very difficult to manage someone who has chronic pain. So this first talk, which is part of the 4PCP program for the management of chronic pain using the biobehavioral approach, is really about this fundamental question: what is pain? Questions to consider in this talk. First, most physicians have a heart sink response when they see a patient on their list who has chronic pain, meaning their heart sinks because they don't know what they're going to do. Another question is, does studying the brain tell us anything new or different about the nature of chronic pain? And the third question I'll ask you is, if you were to stimulate the cortex, where would you put the stimulator if you wanted to reduce someone's pain experience? I'd like you to think about these as we go on about this talk. Now, let's start with the traditional model of pain. Traditional model says pain is a sensory function. This woman in the figure is burning her hand on a candle. The neurons in the hand are firing, sending signals up to the brain, and the brain simply reports back this message as a pain experience. So the brain, in this model, is a reflector of the events message from the body. Now, of course, we've updated this model. This is a model back from the late 1990s. We now know that there are changes in the brain, but really the theory is still that the changes in the brain are secondary to the message coming from the periphery. And the implications of this model is that our primary goal in managing chronic pain should be interrupting the message that goes from the periphery to the brain. But the question is, why has this management approach failed time after time? Are we really addressing pain, and are we really understanding pain in terms of what it truly is? I should say Dr. Janata will use this drawing again for a similar concept later in one of the other talks. So, does the sensory model of pain really explain pain in a way that we can understand? What about people who do this kind of thing, who really experience very little pain, where there is an enormous amount of nociceptive input? Or people that walk on hot coals? Or people that, the football player who fractures his ankle and doesn't realize that the ankle's fractured until he gets to the end zone? How do we explain that if the brain is just simply reflecting a sensory input? Clearly, our model needs expansion. This is a study that Lorimer Moseley did some years ago, where he put a very painful stimulus on the back of young, healthy people's wrists, and compared the reported pain if he flashed a red light versus flashing a blue light. And you can see that the red light was accompanied by pain levels of around 8, while the blue light was accompanied by pain levels of around 5. So why is this? Why can we provide the same nociceptive inputs and have two very different pain experiences? Clearly, nociceptive inputs and the pain experience have to be two entirely different things. So let me illustrate this visually. I want to dwell for a moment on the difference between a signal coming in and the meaning of that signal to the brain. So looking at this picture, this is sort of a traditional optical illusion, but would you say the upper panel is darker or the lower panel is darker? Well, most people would say the upper panel is darker. How about now? I'm going to put a little strip across, and what would you say? Now you would say the two panels are the same. Even going backwards, I can still tell you that likely your brain tells you the lower panel is lighter, even knowing that they're exactly the same. Why is that? Well, the cortex is providing its own inputs into the situation and ignoring some of the visual information that it requires in order to come to an accurate conclusion. So in effect, the brain's saying, I already know the answer, don't confuse me with facts. Well, this is kind of fun here because it's a visual illusion, but when it comes to very emotionally laden things like chronic pain, it becomes it's no longer fun, becomes a very emotionally laden and difficult experience. So I think the first point here is when you're in the office approaching pain, from the patient's perspective, it's all pain. The whole thing is pain. But from your perspective, and if you're going to help that patient move forward in their chronic pain management, you have to yourself understand the difference between the message, which is nociception, and the pain experience, which is what that patient is experiencing, what they're undergoing. So nociception is a signal, it's information, and it's very similar to visual information passed through neuronal signals. The pain experience is how that signal is interpreted and the meaning. If there is significant pain, that means that the brain is making a decision through subconscious brain networks that this signal is a serious threat. So understanding that difference is critical, and the step one in understanding the difference between nociception and the pain experience is understanding this distinction, which is a critical one if one understands the nature of pain. The step two is to understand that if pain is an output, then it must be coming in a large portion from the motor, not the sensory cortex. So if pain is an output of the brain, not an input to the brain, we need to think about it very differently than how we think about it normally. So this slide just illustrates sort of anatomy 101 to understand the differences between the different portions of the cortex. And here is the majority of the motor cortex illustrated, particularly the prefrontal cortex that is very important in chronic pain. And over here is a sensory cortex, along with many other sensory functions, including visual and hearing and other functions. So the point here is the neuraxis maintains a very clear anterior-posterior separation. Anterior is motor, posterior sensory, and this goes all the way from the top of the cortex down to the very bottom of the spinal cord. So the question is, where is the majority of motor activity in patients who have chronic pain? And particularly in those who make progress, where is that activity primary? Well, it turns out that the motor cortex is the primary area in which patients have activity measured by functional MRI when they're improving. This is a group of pelvic pain patients. Also, if you want to stimulate the cortex to reduce pain, you have to do it in the motor, not the sensory cortex. And finally, the areas of the brain that are implicated in what used to be called the pain matrix or the various networks of the brain include many areas in the frontal regions or the motor regions. Of course, there are regions in the sensory areas as well. But the question is, are we addressing pain as a motor output, or are we thinking of pain as only a sensory function? So our paradigm then is incomplete. If we think about most of the pain industry, it's aiming at the messenger. If our pharmacology includes opioids, anti-epileptics, tricyclic antidepressants, devices that are stimulators that try to block the message. But while these are useful, are they really the central way we want to manage chronic pain? And I'm going to propose to you that that's not the case. So the full paradigm would include both the sensory side and the motor side. And the motor side might in fact be a little bit more important. That's the driver of pain. So we've known for at least 20 years, probably 30 years, that the optimal long-term approach for a chronic pain patient is the biobehavioral rehabilitative approach. That was published back in 1999 as a meta-analysis of multiple studies, and it's the single best chance a patient has to have a long-term impact, meaning more than 5 years, for a chronic pain syndrome. And this makes a lot of sense according to this paradigm, because this intervention is the one that really engages the motor cortex, as opposed to the others that seem to stop the signal getting to the cortex. So really, is our English wrong? We say, I feel pain. Doctor, I feel pain. Should we be saying, doctor, I'm making pain? Observations from our chronic pain rehabilitation studies show that functional improvement almost always precedes changes in the pain experience. And breaking the cycle of learned passivity seems to unlock the ability to make progress. So again, motor breakthroughs precede breakthroughs in the experience of pain. So this, in a way, defines the two frameworks that this course is based on for chronic pain. First is the biopharmacologic framework, the one that's taught in medical school, that typically has a dualistic approach. Something is organic, something is non-organic. And if it's non-organic, we think, well, maybe it's psychological. Drugs are primary in the biopharmacologic approach. We try to find medications that will interfere with the message. Physical therapy can be helpful. And psychology we tend to reserve for patients who have psychological issues. The biobehavioral model really eliminates the dualistic approach. It says this person is a whole person. Their pain experience is part and parcel of their pain suffering, and the body and the brain are one. And this is the main approach that is taught in psychology programs from which people become clinical psychologists. This is the approach we think is far more useful to a chronic pain patient because it is motor-based, and is the experience, the programmatic approach we want to endeavor to bring to physicians in this course. So, in summary, what did we learn today? Practitioners have a heart-sink response when they see a patient with chronic pain on their list because they don't have adequate training and they don't have an adequate understanding of the nature of what pain is. The paradigm for understanding pain is partial. We need to include the motor system. We think I feel pain, but we should really be thinking along the lines of I'm making pain, and we need to help patients come to this understanding. The motor cortex may play the major role in pain, since it is the one you stimulate to manage pain. It's the only area of the cortex where stimulation actually reduces pain. The biobehavioral approach provides the best long-term effectiveness and targets motor learning as its major target. Thank you.